dear Federico. So we are happy to see you with us today, the day 2 of our European Depression Day. We are proud that you agreed to contribute to our conference and present your keynote lecture at the closing ceremony, which is very important for us, and it's a conceptual lecture indeed. It's titled Depression, the Polysemy of a Concept. And we see that you are not alone. You are surrounded by your colleagues, a representative of the Argentinian Association of Psychiatrists, and we send you warm hugs from here, from Russia, with love, dear Federico. So welcome, the floor is yours.
Okay. Well, as I was saying, I would very much be grateful to Daria, to Dr. Smirnova for this honor to be here speaking online to the Depression Day, European Depression Day in St. Petersburg, to understand a little bit about depression. We must mention Jaspers, who first noticed that some diseases were understandable, that's Verstehbar, versus some diseases that were only explainable, that's Klärbar. That means that there are some mental disorders that are very next to our feelings, and we have more understandable ways of reacting to our environment. So we get nervous, for example, when we have an exam. So somehow we can reach the feeling that someone with an anxiety disorder has, or we feel depressed, maybe because we have broken a relationship, or even if in the same examination we have failed. So depression is very reachable for us. It's very next to us, so we understand when someone has anxiety, when someone has depression, and we are very likely to make those diagnoses. But in fact, we are not expected, because of being nervous before an exam, to hearing voices. So anxiety symptoms, depressive symptoms are very next to us, and so we sometimes overdiagnosed people with anxiety and depression. Depression itself is a polysemous term, as we will see, or maybe you can call it an umbrella term. So there are different types of depression that are present. Depression can be primary, it can be the disease in itself, or it may be a symptom of a very large quantity of medical and psychiatric diagnoses, even psychosis. So we have at least pedagogically 4 types of depression. We know there's an endogenous depression, in which case we always must differentiate bipolar and unipolar depression. This is very important because treatments are very different. Then we have reactive depression. Reactive depression, which is the opposite in some ways to endogenous depression. Then we'll see the characteristics of reactive depression. Then we have characteropathic depression. That's more common than we think. For instance, depressive symptoms in the context of personality disorders. And lastly, but not least, somatogenic depression, when we have a very organic or toxic case, for instance, having a mild anemia, having hypothyroidism, or consuming some legal or illegal drugs. Let's start by unipolar endogenous depression. Unipolar depression, its cardinal symptom is biotone failure. The German author Ewald told that we have a vital tone, and in this sense, endogenous depression, it's a temperamental psychosis. So we won't expect only to have a patient hearing voices, denigrating voices, imperative voices, but also have a vital tone failure. So in terms of 1 or 2 weeks, the patient is prostrated, it's laid in bed without having any type of energy to do the things that he or she did previously. This unipolar depression has a monomorphic phasic curse. That means that it's a long phase, a long episode, but it's monomorphic in its nature. So the depressive patient will always have the same speech. It will complain always of the same things that will be very monotonous from when he starts his depressive episode until he ends it. And in endogenous depression, and that's why this is a very psychotic depression, we have a transient, not like in schizophrenia, this is transient, break in biographical continuity. This means that there appear symptoms and signs that shouldn't be, even if the patient had another disease. He's not symptomatic for a brief phase of time with reality. This is more frequent in women. This unipolar depression that was first characterized by the Wernicke, Kleist, and Leonhardt school has a late onset, approximately from average 40 years. This means that this is the classical depression, very biological depression, in which a patient may have 1, 2, or 3 episodes in his entire life. Those episodes are always lately developed, and maybe he has an aunt or a grandfather that has had the same disease. These phases in these episodes in endogenous depression are for long duration. Maybe they can still remain 4, 5, 6 months in a row, and if there's no suicide in the middle, they have restitutio ad integrum, so they return to the previous functioning. So in this unipolar depression, there are low numbers of relapses. There is a poorer response to psychotherapy. In these cases, it's not that you mustn't take psychotherapy. That's very important, but these endogenous depressions have better response to somatic treatments such as antidepressants, ECT, TMS, etc. The premorbid personality of these depressive patients are adapted to reality, syntonic with reality, or maybe they may have a melancholic style. So they may have chronic ideas of hopelessness, and that's not good. We know that's related to more suicide attempts. There's a family history of affective disorders, but especially depression. So if, like we said, first episode, long episode coming after 40s, not relapsing very much, and maybe one or two relatives with the same disease previously. Which are the clinical symptoms of this unipolar depression? We have the motor parameter, in which we can have psychomotor inhibition or agitation. Some say that having a depression with psychomotor inhibition or agitation must make us think if it's not a bipolar depression. Then we have slow ideation as a sign, not only as a symptoms, because we will see that many reactive depressives subjectively in their inner speech, they feel that they think slow. In unipolar depression, we see that they think slow, and they have rumination on themes of the past. So they will talk a lot about guilt, about sins, and so on. So they go oftenly to the past in their speeches. Then we have biological parameters. Biological parameters like significant weight loss that's not attributable to season variations, like we all can have season variations of weight, like 2 kilograms in winter or losing 2 kilograms in summer. But great weight loss, such as 6 kilos in 1 week or in 2 weeks. Another biological parameter is the early awakening, when one wakes up 2 or 3 hours before usual, and one has the eyes wide open. You can go to sleep again, and that's the worst period of time in the day. So you have a lot of morning anxiety and anguish, angst. Then we have a lot of biological parameters like constipation. Kraepelin said that one thing that improved when going out of depression was leaving constipation behind. In some cases, in some severe cases, in women, amenorrhea, loss of sexual desire, that's very common. And sometimes these depressions may be season related. Some may begin in autumn, others may begin in spring. So we have the mood parameters. We have the vital sadness. What is this? Kurt Schneider defined that vital sadness was like sadness never been experienced before. It's like the patient saying, okay, I'm sad, but I've never been this sad in my whole life. I know what sadness is. This is qualitatively a different type of sadness. There's absence of reactivity, so this depression is not conditioned by a psychosocial stressor or a trauma, but sometimes we don't need to be confused with the causal explanation of the family members. Family members and friends obviously want to try and connect what's happening with the patient with something that's happened in the nearly past. Not always it's the case here in unipolar endogenous depression. Then in severe causes there are apathy. With apathy, there's no propositivity, there's no plans in the short, medium, or large time. There's a lack of spontaneity, there's a lack of drive. And maybe sometimes they would be associated with anxiety, knowing what we name anxious depression. Again, it must be differentiated from bipolar depression. So we have this depression that may be in part empathetic because we understand some things that the other person is living, but it can be non-empathetic in some aspects. The cognitive parameter could be that psychotic symptoms like mood congruent, delusional ideas, delusions of guilt. Something that's very common in this type of depression is that they interject guilt. So they don't extroject guilt to the surroundings, to the relatives, to the friends, to the boyfriends, etc. That's important to differentiate from, for example, the characteropathic depression. Then we can have delusional ideas of ruin, of sin, hypochondriacal delusional ideas. The delusional idea that psychotic depressives have is the idea of incurability, that they won't be okay again. And of course, ideas of suicide with high lethality methods such as hanging or shooting themselves. More frequently, we have also mood congruent hallucinations that take somehow the voice of the conscience. So the same rumination they are having because they feel they don't are worthwhile, that they are ashamed for their family. They could appear in terms of voices. So there's a transient break in biographical continuity, as we said, but if we go again to euthymia, the person is again syntonic with reality. And so Schneider said that in depression appears morbid exaggerations of basic human concerns, the concern for health, the delusion of hypochondria, the concern for morality, the delusion of guilt, the concern due to economic status, delusion of ruin and poverty, and something that's very important versus what happens with chronic psychosis. It's that they have concerns with relationship with the others, and they could get or have or manifest a delusion of persecution, but with resignation. They think that this conspiracy or these neighbors that are doing bad to them, they are doing it because they know that he's a sinner, and so he deserves it. Right? I won't deepen into bipolar depression, just to say that it starts at earlier ages, 25, 35 years old, even in adolescents, in teenagers. There's a patient history of mania, hypomania, or mixed states, sometimes even of catatonia. They are shorter depressions. They last a few weeks, less than 3 months, but they are more frequent in the lifetime. You can have 6, 7, 8, 10 depression phases. There's greater psychomotor inhibition. It can appear, or you can suspect it, if there's a postpartum depression or if it is an atypical depression. And there appear the Grundzustände of Kraepelin, the basic states that Kraepelin said: hyperactinic personality, cyclotimic personality, or irritable personality. So we saw endogenous depression. Let's quick check reactive depression. In reactive depression, there's a trauma such as an emotional loss or a pathological grief. In women, still bond-related stressors like such as loss of relationships, and in men, loss of achievement. So a man can become depressive because he has become unemployed. This is obviously changing as society changes. Yeah. But this reactive depression, in which there's a psychosocial stressor, is normal. It's in a normal syntonic personality. So there's no personality disorder here. But we all have what we would call an Achilles heel. We all have some aspect in our lives that, if improperly held, we can become depressives. There's a biographical continuity. There's no break in the continuity of life. It's very understandable. It would be very understandable to have a reactive depression after a big loss, and it neither introjects or extrojects guilt. So it's not like endogenous depression, in which it's always my fault, and it's not. It doesn't extroject guilt like in personality disorder. It's my boyfriend's fault, it's his fault, I wouldn't have had a self-harm if he wasn't for him. But in some cases, just like pathological grief entering reactive depression, one can interject some subjects like what if I spent more time with my father that now is dead? What if I have done that or those things? But it's the exception. So this reactive depression has a motivated sadness, which is very in contrast with vital sadness that we've seen before. This motivated is consistent with the trauma. So if I feel depressed because I lost my father, I have a motivation, I have a reactive state in which it only not only it appears depressive symptoms, but anxiety symptoms as well, and somatizations like irritable intestine bowels, hypochondriac, neurotic traits, etc. It has a fluctuating course because we have a clear onset when it started reactively, but its disappearance or persistence depends on having resolved the trauma or not. They have difficulties falling asleep, so it's a very psychogenic type of insomnia. It's that in which we go to bed, we put our heads in the pillow, and we start to worrying about what we didn't do in the past, or being overwhelmed of what we must do in the future, and they feel a non-restorative sleep the next day. That's very common. The worsening of the depression is at sunset. That's very different from endogenous depression. So when the sun is falling down, in the sunset, they feel worse. There are absence of motor or biological abnormalities, so they will tell that they cannot eat what they ate before, that the stomach is closed, but they don't have very huge variations in weight. Obviously, there's absence of hallucinations or delusions or psychotic symptoms. Suicidal risk is exceptional, but still has to be asked. There's no family history of affective disorder required. He may have it, but it's not very important. And something that's very interesting in reactive depression is the way they always want to search for interpersonal contact. So if you have a reactive depression and maybe your friends come and they take you to eat something and you laugh, there you will feel better at that moment, and it's very and then you will feel sad again when they are not there. But there's a lot of reactivity with interpersonal contact, and there's good response to brief psychotherapy. That's psychotherapy here. It's very important and efficacious, and commonly used antidepressants if necessary, such as SSRIs. We are coming to the third type of depression. It's a very common type of depression. We all in consultation would like to have a patient with a reactive depression with no abnormal personalities, but in characteropathic depression there are personality disorders in the base. There are triggers. There are a lot of interpersonal relationship triggers, such as quarreling with the mother, quarreling with a boyfriend, quarreling with someone at work. They have, as I said, abnormal, unstable personalities. This you can see it from adolescence and so on. They have a childhood affective development disorder, so there's no very cognitive disorder such as in intellectual disability, but sometimes they are poorly validated in their own families. They have situations of alcoholism, of emotional, verbal abuse, sexual childhood abuse, and so this conforms this abnormal personality. As we said, it usually starts in early adolescence. This depression in these unstable personalities are characterized by typical emotional storms. So there are depressive rainstorms. There are very brief episodes of depression that may last only hours or days, and in which the patient has an extrajection of guilt. This is very common. So I'm feeling depressed, or I'm cutting myself, or I'm overdosing because my girlfriend abandoned me, or because some friend of mine, some colleague of mine is envious of me, or because I had a quarrel with my chief. These patients are really in an emotionally raw, so they have high standards of emotional dysregulation with deliberate self-harm. Many times not with the intention of die, not non-suicidal, deliberate self-harm, but wanting to have some calm in their emotional situation. And of course, medication overdoses. In the past, only benzodiazepines, but nowadays also benzodiazepines and antidepressants, because they are not very lethal in overdoses. Still, you have to be alert. They have the reactivity to experiences, to memories. Traumatic memories can trigger emotional dysregulation with deliberate self-harm, but even they are very sensitive to biological states or variation of biological states. This type of depression is chronic and erratic in course, so we know that it starts in puberty and adolescence, but it has the shape of a long-term unstable personality that will always give us depressive symptoms and self-harm. One characteristic of this characteropathic depression is the rapid resolution by modifying the environment. This is very common if you work at a psychiatric hospital. You will see that they enter the ward for the deliberate self-harm. They say that they want to commit suicide because they have been abandoned by someone, and 2 days afterwards they are okay. They want to abandon the hospitalization because they are okay again with her boyfriend, with her mother, with and many times families that are invalidating them turns themselves validating when they are hospitalized. So this is such a very pernicious circle. Pharmacological treatment here is not very effective. We don't have effective drugs for personality traits or disorders, so prolonged psychotherapy is needed, oftenly conductual, cognitive conductual, DBT types of psychotherapy. Finally, just to finish our talk, we will simply recognize that there's a somatogenic depression that's organic and toxic in nature. So we can have several medical conditions that can cause depression, like hypothyroidism is very common in families and a lot of feminine integrant of the families, anemia, etc. Drug-induced, like some antihypertensives, corticosteroids, digitalis, interferon beta, interferon gamma, etc. See? And the toxic nature with drugs that depress the nervous system, and in abstinence of drugs that stimulate nervous system, central nervous system. Yeah, this somatogenic depression is characterized we can't only expect a patient that is sad, but patient may be asthenic and adynamic and anorexic. We shouldn't be seeing him or her crying as we would expect. Drowsiness and fatigue can become, and one complication that's not very taken into account is that the somatogenic depression may start like this and may evolve in severe causes, such as people with low cognitive reservation, such as people with dementia, into delirium, confusional states. So we talked about 4 basic forms of depression, but you must know that depression is a polysemic term, is an umbrella term, and there are a lot of more depressions that can be characterized: major depressive disorder, persistent depressive disorder, dysthymia, bipolar depression, seasonal affective disorder, peripartum, postpartum depression, premenstrual dysphoric disorder, substance medication-induced depression, depression, of course, due to medical conditions, psychotic depression, atypical depression, anxious depression, mixed features depression, melancholic depressions, and what we call adjustment disorder with depressed mood that could be somehow related with reactive depression. So this is all. Thank you very much for the invitation. Thank you very much, Dr. Smirnova. Thank you very much, Herzen University, for being honored in giving this conference. Thank you.
Thank you so much, dearest Federico. We would like to say that it's one of the most impressive lectures we had over the whole Congress. Thank you so much. We absolutely appreciate this School of Clinical Psychopathology, and now we share with our second moderator, Alexey Pavlichenko, and we think that this approach to subdivide, to classify depression, the way you present it is really the key way to think, the key approach to think, to understand the concept of depression. As compared to statistical classifications, you know, with all this comorbidity, multi-comorbidity, when we have depression here or there, here is the absolutely perfect approach to understand the concept of depression. So thank you so much, and it's absolutely perfect talk for the closing ceremony. We, you know, with open mouth, we were listening to your lecture, despite we are absolutely astonished by the end of the Congress, and we are very tired, but it's exceptional talk. Thank you so much. Alexey, would you say a few words? Yeah.
Just only, I would like to say that it was some of the most important lecture I have ever heard. Yes, you can combine all different topics with the umbrella of psychopathology. Being a Russian psychiatrist, graduated from clinical psychopathology, it's a method which we studied in our university. And unfortunately, it's not very popular among fellows, young fellows. They are more focusing on other particular topics, and it's absolutely confused by clinical psychologists and psychiatrists. And in your lecture, you are absolutely great. You can combine all these methods. And being a clinical psychiatrist, I understand which is a better treatment, which choice can be chosen in the particular situation. Yes, absolutely great. I'm very impressed, and very short, very clear, very reasonable, and as a doctor, I understand everything. Yes, and I couldn't. I like to discuss. I have a lot of questions in different situations, and now I just only can thank you. Yes, thank you for brilliant presentations, and I think this is psychopathology, clinical psychopathology. It's an umbrella which can combine everything. Yes, and biological, psychological. And modern approaches. Today we have had, yesterday we had a lecture about high-top classification, hierarchical pathological classification. Also, it can be combined within this topic, within this umbrella. Great, thank you. Just only positive, positive emotions, yes.
Yes.
Thank you.
Thank you so much, dearest Federico, once again, and we would like to say that we would be happy to continue our collaboration with Federico, Rebok, and colleagues from the Argentinian Association of Psychiatrists, and we sincerely hope that we would be able to sign the official memorandum of understanding between our Institute of Mental Health and association or your department, whatever, you know. We would be happy to see you next year in 2026 here in St. Petersburg. Fingers crossed, everything will be fine. You know, around.
That will be beautiful.
Yeah. So every time you invite us to Argentina, we only dream to come every October when you have your amazing conference, and absolutely we would be happy if you and your colleagues will visit our beautiful city of St. Petersburg or Moscow next year. Just hope that the time will be peaceful and everything will be solved on, you know, on bureaucratical and other issues. But of course, it's you know, from the bottom of our hearts, we are looking forward to continue our collaboration. Thank you so much once again for our long-term collaboration, and yes, you see more emotions.
Thank you, Daria, for being part of the psychiatric, clinical psychiatry chapter in the association, in the Argentinian Association of Psychiatrists. It's very important for us. You've held a couple of conferences for the Congress, online conferences that were very clarifying. In the last one was very, very, very nice to think that with a paper and a pencil, now with social media, that we can get some markers of this dysthymia, of depression, yeah, or at least depressive symptoms. That's what was very clarifying. So thank you, Daria.